Hello, Mr. Jones, NHS number 123456789, date of birth 30th of the 3rd, 1964. My name's Naomi and I'm leaving you a message from the surgery's digital service. We understand that you attended the surgery for a consultation and the doctor carried out the necessary tests and assessment he needed to arrive at the diagnosis of mild asthma. He established a brief history of presenting symptoms and a family history which provided you with some prior knowledge of the condition, but understandably you had concerns and would like some more information. So I'm going to provide some information corroborated by some academic sources which hopefully will allay some of your concerns and provide you with the information we need. The Global Initiative for Asthma, sometimes shortened to GINA, describes asthma as a chronic respiratory condition with airway inflammation and hypersensitivity. Now, to break that down for you, our airways are structured like a tree with a main trunk and some branches, the bronchus and bronchi and bronchioles. This is our route for oxygen to get into our lungs, where at the point of the alveoli, the oxygen enters the bloodstream, where it can deliver oxygen to the cells, where it's converted to energy at every cell in our body. This is why it's such an important process that we need to protect it and preserve it as best we can with the management that we have in hand. The Asthma and Lung Foundation currently have it at 7.2 million adults diagnosed with asthma in the UK. And Professor Hull of St Guy's and Thomas's Hospital in 2026 described it as he stated that asthma caused by allergies is the most common cause, accounting for up to 60% of current diagnoses. And when I say allergen, I'm going to break down that definition about airway inflammation and hypersensitivity. It is the inflammation could be described as an allergic response, but it can also be described as an inflammatory response, because that the trigger could be something extrinsic. It could be a traditional allergen like pet dander, like house mites, like dust, sprays, perfumes. But it can also be something trigger that's intrinsic, something within you. It can be if you have been laughing, exerting yourself through exercise, or if you have the flu, which is why as an asthmatic you qualify for the flu vaccine, and we'd encourage you to keep up to date with all your vaccines, because somebody with asthma is more likely to suffer a worsening of symptoms if they do contract the flu. The Price in 2021 writes that the asthma is part of a cluster of diagnoses where somebody such as yourself who has a predisposition to things like allergic rhinitis and atopic skin inflammatory disorders is more likely to be diagnosed with asthma as part of that cluster. You may find that some of your allergens that trigger some of your other inflammatory responses also trigger your asthma, but it may be something completely diverse to that, and it is a case of becoming more familiar with the triggers that affect you and can lead to exacerbations. In terms of exacerbations, this is where the airway I'm talking about, it is encircled by smooth muscle, and when you have an exacerbation or an inflammatory response, that muscle tightens and constricts and narrows the airway and narrows the amount of space there is for air to move in and out. This can create an audible rasp, a wheeze, a stridor. This is something that can be heard by yourself in the early stages of it becoming worse, or by those around you, which you can ask them to listen out for and help advise when it might be time for you to take your inhaler. This is a sign that the airway is narrowing. Also, when you have goblet cells in your lungs which are constantly producing mucus as part of the normal function, but during an inflammatory response they produce even more of this mucus, and this further compromises the amount of space available. So if you did have an acute exacerbation, this is sometimes called an asthma attack, we would expect you at this point to take, or we would ask you at this point to take your reliever blue inhaler, which contains a bronchodilator medication called salbutamol. It opens the airways. You need to open the airways to allow more air in, because we can't have a reduced, compromised supply of oxygen. You take your reliever inhaler, and it should start working within 5 to 10 minutes and last 4 to 6 hours. If it isn't doing what it's supposed to do, you take it again as prescribed, as directed, and you phone 999. If you require treatment within the hospital setting, you can have the salbutamol bronchodilator medication administered through a nebulizer. You may be given steroids. It's for the doctors to decide what's caused this onset and how best to mediate and medicate this. For treatment at home, continuing, you will be told about your inhalers to take with a spacer. You'll be told to mix the medications in the canister. This is inhaled corticosteroid called beclometasone. You will put it into the end of the spacer. You will take 10 normal breaths in and out, and that will allow the medication to be delivered to where it needs to go. And you will be told to take this. As we know with steroids, the regularity is crucial. To take it to stabilise the condition, take it consistently, regularly, as prescribed. And the blue inhaler is the step up if you're short of breath. That is the regime advocated by Gina. At times of exacerbation, you may also be prescribed prednisolone steroid tablets for a short-term course to help boost you, but it's not a long-term treatment, whereas you can also be prescribed anticholinergic tablets to reduce the amount of mucus you produce, something like Montelukast, which can also help alleviate symptoms. There has been review in recent years by Farinia et al., who, writing in 2025, describes inhaled medications as the cornerstone of asthma management. So we will look at that technique when we have you in the surgery to make sure that it is correct, because if it's not correct, then you are not getting the medication delivered in the way it's intended, so it's not going to manage asthma in the way that it's intended. Dr. Neil Tucker, writing in 2025, argues that the MART, the maintenance and reliever therapy acronym, is a far superior regime to the Gina advocated step up. The difference with the MART regime is that it contains the inhaled corticosteroid, but instead of beclometasone is budesonide, and instead of the short-term salbutamol bronchodilator, it contains a longer-acting beta agonist bronchodilator called formoterol, which is designed to last 12 hours. As I say, Tucker argues that this is based on information from the Primary Care Respiratory Society in 2024, a superior regime to what is advocated by Gina, but that is a debate between yourself and the doctor, where you look at what your triggers are, what your patterns are, and what works for you with your symptoms. In terms of establishing that, before your diagnosis, you will have completed, or hopefully you will have done, a peak flow diary. When you do your peak flow diary with your peak flow meter, you'll be aware that it's best to stand up straight, do a full out breath into the peak flow meter. For a person of your height, age and weight, we would expect that little red arrow to fly along to between 4 and 700 on the scale. You take the best of 3, jot it down in the chart for that time and that day, and then you can draw a little line graph and you can see where your highs and lows are. Your normal should be anywhere above 80% of your personal best, and you want to maintain that. And if not, you want to be able to see the times where you haven't maintained that, and if there's reasons behind that. Is becoming acquainted with the reasons why you might not be maintaining your personal best that helps us best mediate, medicate and manage your asthma. The aim of controlling asthma, to have well-controlled asthma, is that you're not using your reliever inhaler. That is well-controlled asthma, but we have it just in case. We aim that you're not using that more than 3 times a week, and you're aiming that you're not being woken up more than once a week. If those things are occurring, then we would call that less well-controlled asthma, and we want to have more regular asthma reviews to try and get on top of it. It may be that there are external, extrinsic triggers that we can't control, that are environmental, or illnesses within yourself that, again, some things are beyond our control, but for things that are within our control, we develop a personalised asthma action plan. And for that, we need to keep track of your peak flow meter. We need to make sure that you have good technique with your inhalers. We need to make sure you're up to date with your immunisations, and a bit of ownership from yourself as well about what your signs and symptoms and what you can do to help manage this. Sometimes better improvement in diet and exercise, or cutting down on anything if you were to smoke, or sprays and perfumes like that could be things that are good to cut out to try and help preserve your good respiratory health. Pjorsberg writes in the Lancet in 2023 that we're entering an era of precision medication. There are some asthmatics who are being treated with biological therapies, which work by targeting and blocking specific molecules in the immune system that cause airway inflammation, and they're even entering remission. So it is possible to have targeted treatment that is specific to you and your conditions that we can work together with in partnership to try and help limit how much asthma impacts on your life. But this is a very much person by person, person-centered care, specific to you approach, and we will have to work together to establish what that is for you. Henry writes in 2021 that the personalised action plan is where it's best for us nurses to try and remind the patient to stay within the green zone of understanding what medication to take and when, without entering into the yellow zone of when it worsens, or the red zone of what to do in attack. But as described, that would be to go to 999 once you've taken your own bronchodilator. But we're hoping it doesn't get to that stage, or when it does, that you manage it well and that we can help you. I hope that information is as full as possible. If not, I would signpost to Asthma and Lung UK and the NHS information that's available online, or contact the surgery for any further in-person information.